So good afternoon. I have been both challenged, inspired, and in some ways I have been alarmed by some of the information I heard this morning as it relates to the challenges of a caregiver. And although at the end of the day, I think we all have a responsibility in how we take care of those who are most vulnerable. Me hearing about that, and even from the caregiver whose husband passed from cancer, really challenges me as a physician. So one of the things I'm going to talk about for the next 10 minutes has to do with what I consider to be the answer to all of those woes. And some of you are going to say, sure you are, sure you are. I also would like to say, because I recognize we just had lunch and I know how the brain works after you've had lunch, if you want to stand up, please feel free to do so. So I'd like to talk about what I consider to be probably a well-kept secret, in that there's not more known about PACE, which stands for the Program of All-Inclusive Care of the Elderly. And as I heard about the challenges of the caregivers this morning, as I heard about the challenges around providing care for that special needs daughter, as I heard about the challenges of the caregiver with the husband who really didn't get what she needed from the healthcare system, physicians in particular, that would be me, it made me realize that there is a care model that does address each of those. And I'm going to tell you a little bit about what that care model looks like, but I think the challenge at the end of the day is, why don't we have more of that care model? And so that's what I'm going to put on the floor. Now, I have some thoughts about why I think we don't, but this is the place where we decide we're going to leave from here. We're going to make something happen. So we're going to leave here with some action plans about how we can make some changes around the program of all-inclusive care for the elderly. So I am going to, who did that? Thank you. So when we think about PACE, or the Program for All-Inclusive Care of the Elderly, you've heard these terms already, and it has to do with a population with the highest need, the highest cost. PACE sometimes will refer to them as frail, older adults, but as we're looking at how we can expand to look at more than just the older adult. Now, let me say this. When I first came to PACE in 2001, the average age of our PACE participants was 85, 86. And at that particular time, that was old and I was young. Now, almost 20 years later, the average age of PACE participants is more like 73. So they're getting younger and I'm getting older. So what I'm seeing is I am seeing somewhat of a paradigm shift too, in terms of who is appropriate for this program. But what I want us to leave here with today is that the average age of a PACE participant could be 22. Or could be 35, if we recognize that this is a model that brings all of the entities that we've talked about this morning that are missing. All of those gaps, I feel, can be completed and filled with PACE. So we talk about this really vulnerable population, many psychosocial needs, they're disabled, and this is a poor population is usually. When you also think about this population, and we've heard this morning too, their care has been fragmented. One provider provides care in one place, they go to the hospital, another provider provides care, they have to go to long-term care, another provider provides care. Let's not even talk about transitions of care or med reconciliation. For physicians, that's a nightmare. So the care is fragmented and they're at high risk. They're at high risk for hospitalization. They're at high risk for poor outcomes. They're at high risk for not receiving the care that they need. They're at high risk for drug-drug interactions, disease-drug interactions. So all of the things you can put behind high risk, this population is at risk for it. And that is exactly what we've talked about this morning. So there has to be a solution, folks. And we do have a solution. We need to figure out how to make that solution. How do we duplicate that solution? So why integrated care? I love this article. It was in New York Times last year. You can go ahead. And it talked about, and I tell you, this is profound, and many of you probably saw this. It said people want health, not health care. They're getting plenty of health care, but they don't want health care. They want health. And those who require the most health care get the least health, high need, high cost patients with multiple or severe medical problems. They feel this most acutely. So this again identifies a population that if we're not careful, the healthcare dollars will follow them. And I don't want to say where those dollars are going to go because I don't think it's going to end up in health. So people want health, not healthcare. You can go on. So what does an integrated model of care look like? And that's what PACE does. And I want to kind of expand or broaden our thinking this afternoon about what is integrated care. Well, one of the things that we know PACE does, and they do it uniquely, and they do it very well, is they integrate the medical care and the financing. That's kind of unique for us. So we are the insurance, but we're also the healthcare provider. And the benefit of that is it gives us a lot of leverage in terms of the types of things that we can do for caregivers, in particular for the services and where the services need to be provided. We also are integrated in terms of acute care and long-term care. So acute care in the clinic, acute care if they need to go to the hospital, long-term care, we like to consider ourselves, we are able to provide long-term care or nursing home care at home. So we can provide all of that. That's part of the integration. Behavioral health and primary care. You all know that a hot spot for this country is going to be behavioral health and how we're going to provide those services. The number of behavioral health professionals is doing this, whereas the number of people who need behavioral health services is doing this. So PACE has the ability to also provide that integration. The interdisciplinary care team, I really believe, is the sauce that makes us really work well. We have an integrated interdisciplinary care team that is able to provide the resources. That's a social worker. That's a nursing assistant. That came up several times this morning. That's a home care aide. That's transportation. That's a nutritionist. That's an RN case manager. The physician and the nurse practitioner, we're important, but we're not as important as some of those social components. And that's another part of the integration. And then, of course, the medical and social components of care. You can go ahead. So why PACE? What has PACE been shown to do? I did not actually include the articles on each of the slides, but I included the articles at the end of my presentation. So that will be available to you so that you can go and pull up the articles, okay? We know that people in PACE report they report a higher sense of self-care. Their self-health report is higher. We know that there is a reduction in premature nursing home placement, reduction in hospitalization. That's been shown. The PACE literature has a lot of information about that. We also know that it reduces fragmentation of care. And again, you've got a team that follows a person wherever they are. They follow them from the hospital to the nursing home back into the community. So it eliminates the fragmentation. It also, there was an article by Onlock in 2005, I believe it was, that talked about how PACE can actually impact the care of African American older individuals. And they compared white older individuals in PACE and black older individuals in PACE, and the black older individuals in PACE actually had better outcomes. So when we start talking about health disparities and disequities, then we can see that PACE may also be able to provide that caregiver support, and then of course lower costs. Let's go in because okay. So the benefits are all of the above. You have, before value-based care became the buzzword, PACE did value-based care. It's not fee-for-service. We are given a certain amount of money, it's per member per month. You get a block of money each month, and everything that individual needs, wherever it is, you provide it. Social services in the home, transportation, whatever the services are, they can be provided. We consider ourselves best practice. Again, the opportunity to be both the insurance and the provider is a unique, and initially I was a little bit challenged by that coming from the other side in healthcare, but now I find that we take advantage of that and you can really leverage that to be able to provide services for this very needy population. Go ahead, because I know keep going. Keep going. Okay, I wanted to talk a little bit about the barriers, and I'm going to go back. Some will challenge, why, if this is so good, why, if this is as good as you say it is, why, if this can really provide what you say it can provide, why haven't we heard more about it? Why are only 45,000 people right now served by PACE? And you know, the present estimate is there is roughly 11 million people that are dual eligible. And we're not even talking about the younger dual eligible. I'm talking mostly about the older dual eligible. So why haven't we heard more about it? What are some of the barriers? And those are going to be our challenges today. Understanding PACE and its benefits. Competition, that's just the reality. It's not something that people want to talk about, but there are other managed care programs or other waiver programs that PACE may appear to be in competition with. I don't think so, because with 11 million people who are dual eligible, how could there be competition? There's enough work for everybody. Startup costs for a PACE program, I think it's been estimated, Joanne, you can correct me, of about $700,000 from start to finish. You've got a building, you've got to put in what you need to put in the building. It has another so it's built, she just corrected me, 7 million. So what we see is that the cost of startup, just the capital costs, not to mention the people costs. You have to have people to take care of these folks if you're actually going to open a program, and that's been another challenge. And that challenge is not just having people, but is having people trained and skilled to be able to take care of this population who want to do it. Everybody doesn't enjoy taking care of frail older adults, let's face it. It's not everybody's forte. So you have to have the right skill set as well. Spin down, limitations on the number of people served. You know, there's this big thing right now that we're looking at with the Innovations Act is we want to be able to find people who are younger, just like the case that we heard this morning, who are younger but who would benefit from PACE. Everything that PACE has, that family would have benefited from. Not only would the patient have benefited, but the caregivers could have benefited from that. So we need to look at how do we expand this? How do we broaden it to other populations? Joanne told me about something that I don't want to forget here, and that has to do with the Medicare-only Part D barrier for people coming into PACE. So if a person only has Medicare Part D, if they come into PACE, their Part D is not, if they only have Medicare, I'm sorry, their Part D is not covered. So what we need to do is CMS is beginning to look at this and give some more thought to this. We need to really advocate for pushing that barrier out. A person with Medicare only should be able to come into PACE and have their medications provided. My understanding is they will pay PACE a certain number of dollars, and then PACE would go out to the marketplace and make certain that the medications are provided. So that's one of those areas that we can advocate for in terms of action steps and where we can go from here and what we can do. And it's SEMA Verna. So if you want to get in touch with your congressperson, it's SEMA, SEEMA-VERMA. Please text, please email, and let her know, open that door for us. Push open that barrier against people not being able to benefit from PACE with Medicare only. Go ahead, because I want to finish up. Now, go back now. So when we talk about, go back one more time. Go back again. Go back again. So one of the things that I've said, and I know I'm making this fast, but I really want to stay on time. When we talk about the team and PACE, the integrated service delivery is essential. There is no PACE without it. And the integrated service delivery consists of every discipline imaginable. And one of the beauties of PACE, unlike many traditional models where the physician is the do-all, say-all, be-all, that is not the case in PACE. The individual that has a particular need, that discipline that can provide that need becomes the primary driver of that need. Now, the rest of us are there, but they become the driver of that need, and I think that's important. Go ahead. Go ahead. I want to share, hopefully during the Q&A, I really want to share the case study because it allows you to see, that's what this is, it allows you to see really how PACE works. Keep going. Go ahead. So where do we go from here? NPA Strategic Plan. The NPA has been ahead of the game and has worked tirelessly on looking at how do we go to the next level. What do we need to do to be able to expand PACE? What do we need to do to be able to both expand the population? But you know, at the end of the day, as much as I want to expand the population, I would like to be able to make certain that every person right now that qualifies for PACE could get into PACE, not because they make $5 over. I'd like to see us be able to expand how we're able to make this service available to them. So these are their pillars. It's champion the value of PACE and support growth, advocate for effective regulatory and payment policies, support PACE operational quality through education and data, and distinguish and promote the PACE brand. I want to say again, similar to what Dr. Stone said, we have to look at the root cause of where some of the biases and some of the inconsistencies are. And I really feel that education is going to be important. For me, it starts in high school, it goes on to medical school, it's residents. We have to first make certain that people want to go into careers to be able to provide these services, because without them, we really won't be able to expand them. Go on. Take-home lessons, it'll be on your slides because you'll get them. Go on. Go on. Yeah. And so this is a group of our PACE participants. They went to the Capitol. There is an Older Michigan Day every year, and they go to the Capitol, and they have a choir, and they tell the Capitol, this is why we need funding. This is who we are. This is what we need you to do for us. And it is always so well received. The folks on the Capitol love to have them come. The participants are glad to be there and share their stories. And I just wanted you to see a group of the people that we take care of and a group of the people that we're committed to provide care for. So PACE is the way of the future. It is here to stay. We just need to make certain that some of these barriers and obstacles that we can overcome collectively as a group and also individually. SEMA Verma, make certain that goes back, okay? Thank you so much for your time.